Good evening, everyone. Thank you for coming along to this Monday night webinar, or if you're listening back, thank you for listening back. For those of you that are booked on the live event, thank you. Sorry about the change in date. That was a bit short notice, but thank you for being so accommodating. And obviously, thank you for CPD.me for inviting me back. So I've done a couple of these webinars now. So if you're a regular listener, hello. We're getting to know each other, hopefully. So tonight we're going to be talking about 5 surgical emergencies not to miss. And we're going to be doing this in a bit of a case-based format. So just before we start, by surgical emergency, I'm talking about conditions that would usually be managed in hospital by a surgical team. So these are patients that may be admitted to a surgical assessment unit and looked after by a surgical specialty. So that's what I mean by surgical emergency. Not all of these conditions may require an operation, but a lot of them would require surgical input. So just so that we know what we're talking about, that's what we're going to be discussing tonight. And just a little bit of a health warning, there are a couple of photos in this session that if you're very squeamish, you might not want to look at them. So I'm just a little health warning before we start. There are a couple of photos. So my name's Chris. I'm a clinical teacher. I work for a medical school in the north of England. And this is Maggie the dog, who makes an appearance on all of my presentations. And if you listen back to any of the previous recordings, you will see other photos of Maggie. But this is her enjoying her favorite walk. So there we go. So if anyone's got any good pet photos they want to share on Twitter using the hashtag, then please do. Maggie would love to meet them. So as I've already mentioned, we're going to talk about some surgical emergencies that you don't really want to miss in clinical practice. We're going to use a case-based format. So I've got 4 cases that I've written. And we've also, just to finish off with at the end, got 1 spot diagnosis. So in order to make this a little bit interactive, as we work through the cases, have a think about potential diagnoses. So think about forming a differential diagnosis. We don't have lots of time in order to pause and really mull over these diagnoses. But if you're listening to this back as a recording, you can always pause the recording if you need more time. And then if you want, you can share these differentials in the chat box. So just type in your thoughts about what the different differential diagnoses are. And I'll try and keep an eye on them as we go through. Or if you've just got a pen and a paper at home, then you can scribble down your thoughts on the diagnoses. So we've talked about this before when we talked about the 5 medical emergencies not to miss. So just so we're kind of thinking on the same page, I'm thinking about clinical reasoning here when I'm talking about differential diagnoses and diagnoses that you don't want to miss. So I think I've talked about this before, but just memorizing facts and memorizing a textbook doesn't necessarily make you a good clinician. And by clinical reasoning, we're thinking about the decision-making processes that are associated with clinical practice. And diagnostic error is common due to errors in our thinking and our clinical reasoning. So in this presentation, we're going to be thinking about diagnoses that you don't want to miss. And the mnemonic card is a good way to think about diagnoses when you're assessing a patient who's got a presenting complaint. You think about, what could be the common cause for their condition? Could this be an atypical presentation? Could this be a rare disease or condition? Or is this a don't miss diagnosis? So hopefully that's so that we all know what we're talking about with a don't miss diagnosis. And there's a previous webinar on the CPD.me platform that talks about clinical reasoning in a bit more detail. So I would recommend that. Right, so I've talked enough. Let's have a go at our first case. So be prepared on the chat box or with your bit of paper if you're scribbling along at home. Okay, so our first case is leg pain, a very common and seems relatively benign presenting complaint. So this is our first case of leg pain. So let's have a look at this in a bit more detail. So we've got a 61-year-old, and he works as a lorry driver. So he's a long distance lorry driver, and he's presented to you with a relatively short history of worsening pain in his right foot and calf. So he says it's, he's a bit vague, but it's come over on about 3 to 4 hours. He's tried some paracetamol that he had in his lorry, didn't really help with the pain. And he's racking his brain. There's no history of trauma. He can't think of anything he's done to his leg. He hasn't fallen over anything. He hasn't had any history of trauma that he can recall. When you ask a bit further, he's had some intermittent pain in his right leg before, but he's never really thought much about it. Sometimes it comes on when he walks long distances, but he tells you exercise is unhealthy. So he tries not to walk long distances. And he doesn't really have any other symptoms. He doesn't have any chest pain, shortness of breath, no hemoptysis, and he hasn't had any blood clots in the past. So he's never had a PE or a DVT before. In his past medical history, he's hypertensive and he's obese and he's a smoker. And he's maybe on some medication for his hypertension. So it's worth probably just thinking about at the moment what our differentials are already. So we've got a 61-year-old who's presenting with kind of right lower limb pain. So maybe have a think about what your differentials are just based upon the history, and obviously feel free to share them. So moving on, so you decide to have a look at his leg, and he's really hobbling around your clinic room. So when you have a look at his leg, it looks a bit like this. So it looks like the leg on the right here. It looks pale, and it's got this kind of dark bluish discoloration to the foot, and it just generally looks different to the other leg. So it's pale, maybe even a little bit cyanotic is what it looks like. So this is what the leg looks like. He's in obvious pain. He's unable to weight bear on his leg. He's a little bit tachycardic. He's got a heart rate just above 100. And his heart sounds are irregular, and he's got an irregular radial pulse as well. Maybe your ECG machine is broken, but it's definitely irregular. And his leg is as pictured. It's very painful. It sounds cool. It feels cool to touch. And when you try and feel for his dorsalis pedis and his posterior tibial pulse, you can't really find anything in that right leg. So putting this all together, it's probably, hopefully we can think about what our differentials might be here. So we've got a 61-year-old man presenting with leg pain. It's come on relatively acutely, and he's now presenting with a cool to touch, painful leg with impalpable pulses. So the diagnosis here, as someone has suggested, is hopefully relatively straightforward, but something that you really don't want to miss in clinical practice. So this man has got acute limb ischemia. So he's developed an acutely ischemic right lower limb. So acute limb ischemia is where it's just a sudden decrease in limb perfusion, and this can threaten limb viability. And that makes sense, doesn't it? If your arterial supply to your limb is suddenly disrupted, then that's going to cause tissue ischemia, then it's going to cause necrosis and death of tissue. So acute limb ischemia is a vascular emergency, and it's got a high mortality and morbidity associated with it. There are some risk factors. So these are your atherosclerotic risk factors. So think of our man. He's hypertensive, he's obese, and he's a smoker. So all of your atherosclerotic risk factors increase your risk of having what we call peripheral arterial disease. And you may have heard of this term before. This is where you get furring up of your peripheral arteries, most commonly in the legs. And patients can present with a symptom called intermittent claudication, which is basically angina of the lower limbs. So when they walk, they develop pain in their calf and in their leg, and that pain eases when they rest. So it's the same pathophysiology, isn't it, as angina, except that angina is chest pain brought on by exercise because your heart is working really hard, whereas intermittent claudication is pain in your legs because your muscles are becoming ischemic, because your arteries are all furred up. So there may be a history of peripheral arterial disease and intermittent claudication, which is what our man had, but not always. Some patients may have no history of this, and their first presentation is when they have an acutely ischemic limb. So the reason for this is there's kind of two broad categories of pathophysiology of what's going on here. So you can either have an embolism or a thrombosis. So if you have a thrombosis, then you've got an atherosclerotic plaque in an artery in your leg. That plaque suddenly ruptures, and then that causes an acutely ischemic limb. So that's the pathophysiology we're familiar with when it comes to a myocardial infarction. The other pathology that can happen, though, in acute limb ischemia is an embolism. So this is where a piece of thrombus has broken free and traveled from elsewhere in the body. And this can occur in patients who've got minimal risk factors for atherosclerosis, but they may have risk factors for developing emboli, such as a history of atrial fibrillation, which we can see here on the slide. So it's always worth remembering when you're thinking, could this patient have an ischemic limb? Yes, they may have all of the risk factors. They may be a smoker, they may be overweight, they may be obese, etc. But some patients may have minimal risk factors. And in fact, this is an embolic event due to atrial fibrillation. And the signs and the symptoms tend to be more severe with an embolism because it's much more sudden. So that's just a little bit about the pathology. So our man, sounds like he may have had an embolic event because he's got an irregular pulse. Maybe he's got some atrial fibrillation. So when we're thinking about the signs and symptoms of acute limb ischemia, I'm sure some of you will have heard of the 6 Ps. I'm sure some of you will have heard of this. This is what it's even in the NICE guidance for peripheral arterial disease. So it's quite commonly taught. So when you're thinking, could this patient have an ischemic limb? We think about the 6 Ps. So these are pain, paralysis in the limb, pulselessness, so you can't feel a pulse. It feels perishingly cold, pallor, it's pale, and paresthesia, so altered sensation. So this is a great way of remembering the signs and symptoms of an acutely ischemic limb. Just to point out, though, that the clinical picture can be very variable. So you don't need to have all of these 6 Ps in order to suspect the diagnosis. So generally the first findings are a whitish appearance to the limb, absent limb pulses, and a cold limb. Paresthesia and paralysis are much later signs. So that's quite bad. If you've developed paresthesia and paralysis, that suggests a poor prognostic outcome from your ischemic limb. So it's worth remembering these, especially when you're thinking, could this be a DVT? Could this be acute limb ischemia? Remember the 6 Ps. That's what you're looking for in acute limb ischemia. So what are we going to do for this man? Well, obviously we're talking about surgical emergencies. So these patients need to be seen by the vascular surgeons. So they take the lead on managing these patients with acute limb ischemia. Some of these patients can be really unwell, especially if they've had a delayed presentation. They can be quite horribly unwell. So it's always good to obviously take an ABCDE approach. They need lots of good analgesia because it's a very painful event. And medically, we would often, unless there's no significant contraindications, start some form of anticoagulation in the acute setting. We need to think about some form of imaging in order to map out basically where the obstruction is, because it's a bit like plumbing, isn't it? You need to find out exactly where the blockage is. So there may be initial imaging with ultrasound, but CT angiography is going to be the gold standard. And then the definitive management varies depending on where the obstruction is, but normally it may involve some form of vascular surgical intervention, such as cutting out the clot or doing a bypass. And then in the long term, you need to reduce these patients' cardiovascular risk. So they have to stop smoking, etc. But the bad thing about this condition is it's associated with a really high mortality. So it's approximately 20%. So kind of 1 in 5 patients, this is going to be a pre-terminal or terminal event. And it can be kind of quite a distressing presentation, especially if it happens in people with lots of comorbidities who are not fit for surgical intervention. You can have to have some quite difficult conversations with families. Even if intervention occurs, so even if we undertake some form of vascular intervention, there's a risk of reperfusion injury, which I guess is similar to a crush injury, isn't it? You always talked about, when you suddenly release a crushed limb, then you can develop hyperkalemia, other metabolic abnormalities, acute kidney injury, and renal failure. Well, the same thing can happen if you suddenly reperfuse a limb that's been ischemic for a long period of time. So these patients may require intensive care input as well. Sadly, if there's irreversible ischemia, so if we've missed the diagnosis or it's a delayed presentation, then maybe the only approach left would be amputation of the limb, or even a palliative approach if the patient isn't fit for amputation. So it's always worth, so from a medico-legal perspective, because the rate of complications is so high, and because if we delay intervention, there's a risk that patients may require quite significant surgery, such as amputation, it's always worth being able to perform a good vascular exam and knowing the signs and symptoms of acute limb ischemia. So in the CPDME Facebook group, for those of you that are members, I'll post a link to performing a lower limb vascular exam, because I think that's a really good skill to have. And just in all of my webinars, I feel like I put in some form of medico-legal case study, but this is just an example of a case of missed acute limb ischemia. And this is a patient that actually presented several times. They presented several times to their GP, and then they presented to A&E and were sent home from A&E, despite quite clearly having an acutely ischemic leg. And the outcome of this was that sadly the leg wasn't salvageable and he had to have an above knee amputation. And I think the NHS paid out quite a significant amount for this. So when we're thinking about documentation, it's really important that not only are we examining limbs well, that we're also documenting them. Fine. So we've talked about, how are we doing? We've talked about leg pain, and we've talked about an acutely ischemic limb, which is really good. And we've talked about some of the management options. And like I said, I'll post some stuff in the Facebook group about performing a vascular exam, because that's a really good skill to have. So let's move on and have a look at our second case. So this is a case of testicular pain. So for those of you maybe working in the pre-hospital setting, maybe this isn't something that you go to a lot, but certainly for any of you working in maybe primary care or more practitioner type roles, or doing any form of triage type roles or event work, this is a not uncommon presenting complaint to urgent care type settings. So let's have a look at this case. So this is a 17-year-old, so this is a young patient. So obviously this has happened pre-lockdown, because he maybe wouldn't be playing football unless he's a Premier League player. But so he's basically presenting with scrotal pain. And he describes yesterday he was tackled a bit awkwardly, maybe had some scrotal trauma, wasn't really sure, it was a bit of an awkward tackle. Wasn't that bothered at the time. But today the pain has suddenly got really bad and it's spread all over the lower abdomen, and it's really significantly worsened, and there's no relief with painkillers. He's kind of taken everything that he can find at home, and it's still really painful. He feels really nauseated, and as if he might vomit everywhere. So he doesn't have any infective symptoms. So he doesn't have any fevers or rigors. It doesn't really have any urinary symptoms, no dysuria or frequency. Hasn't had any recent sexual activity, no new partners. And he's otherwise fit and well, so hasn't had any surgical history. He's independent, he's a football player. So it's maybe worth thinking about what your differentials are here already. Always good to think about the differentials for this case. Good. So you move on. So you've maybe done some, if you're trained, you can do a testicular exam, if that's something that you've been trained to do, which I know anyone working in a practitioner type role probably will be happy to do that. So firstly, he looks quite unwell. Well, he looks really pale. He just looks rubbish. And he looks as if he's going to vomit. And when you kind of examine his testicles, he's got quite significant scrotal edema with some overlying erythema. And then on examination, you notice that his right testicle is a bit higher than his left testicle. It's very tender, and he's got an absent cremasteric reflex. So for those of you that aren't familiar, the cremasteric reflex is a superficial reflex that's elicited when you stroke the inner part of the thigh. This causes the ipsilateral testicle to rise upwards. It's actually using the L1, L2 nerve roots. Good. So he doesn't have that reflex. If you haven't heard of the cremasteric reflex, you can maybe Google it, and then maybe you can try it on yourself or your your partner. I don't know if that's something that you want to do. If you want to try it out, then maybe do so. Yeah, good. So lots of people have are obviously picking up on the diagnoses here. And there's obviously, this is a diagnosis that you don't want to miss. So this is a man presenting with acute scrotal pain who has got an absent cremasteric reflex, whose one testicle is higher than the other. So he's got testicular torsion. So just a health warning about the images. I'm sorry. It's just the easiest way to kind of talk about it. So testicular torsion is kind of as the name suggests. So that occurs when the spermatic cord and its contents, they kind of twist around, and that compromises the blood supply to the testicle. So therefore your testicle becomes very ischemic, and within hours it will infarct. Okay, so obviously it's testicle threatening. We can say that rather than life threatening. We can say it's testicle threatening. So this is a surgical emergency, because obviously the consequences of losing a testicle are pretty devastating if you're young and you want to start a family, etc. So testicular torsion can theoretically occur at any age, but you need to watch out for it in neonates and in adolescents, normally post-puberty. So maybe 17, 18, 19, 20-year-olds, early 20s. This is when you need to watch out for testicular torsion. So it's not good. And obviously this image here is an intraoperative image, and you can see that the spermatic cord is all twisted around, and you can see the color of the testicle is quite dark. So it's a bit, it's not looking great. It's an unhappy testicle. Fine. So this is testicular torsion. So this is a diagnosis that you don't want to miss in a patient presenting with scrotal pain. So as we've talked about, it's usually affecting young males, and this is a urological emergency. And because you're going to get interruption in blood supply with ischemia and infarction of the testicle. So what are the clinical features of testicular torsion? So pain, and classically it's sudden onset. So sudden onset pain. Patients, there's maybe nausea and vomiting, scrotal edema and erythema. You may find on examination there's what we call a high riding testicle. So the affected testicle is higher than the unaffected testicle, and it may be lying in the horizontal position rather than the vertical position. And there may be this absence of this cremasteric reflex. So these are the features. However, the problem is that this is notoriously difficult to diagnose, and there's no single clinical feature that will make the diagnosis for you. It can be a very variable presentation. So you should have a very low threshold for suspecting testicular torsion in kind of any man presenting with an acute painful scrotal swelling, particularly if they're in the correct age range. So if they're younger than 30. So have a very low threshold for suspecting this diagnosis. And because it's so time critical, the role of imaging is relatively limited. So the definitive, lots of these patients will just go for an exploration. So they'll go for a surgical procedure. And lots of the times they won't have testicular torsion, but we don't have a reliable way on clinical examination of completely excluding this diagnosis. So it's notoriously tricky. For those of you that are seeing patients with scrotal pain in clinical practice, it's not my favorite presentation because I'm always worried about torsion. But there are obviously other things that can cause testicular pain, for example, an infection, epididymal orchitis, etc. So I'll post a link on the Facebook group to a great resource from the Royal College of Emergency Medicine about how to assess patients with scrotal pain and edema, because there are other differentials here. So what's going to happen to our man with his testicular torsion? So we've talked about this already. It's a clinical diagnosis. And if you suspect it, then you need to ring up urology and they need to come and do something, even if it's 3 o'clock in the morning. So what will happen is testicular exploration is kind of what we're going to aim, what they'll probably aim for. And then you can do orchidoplexy, which is where you fix the testicle to the side of the scrotal wall. You kind of untwist it and fix it is the best way to describe it. It's surgery, isn't it? It's like, yeah, manual labor. So that's often what happens. Sadly, if the testicle isn't salvageable, so if we've delayed the diagnosis, or I don't know, the patient presented late, etc., then you may have to remove the testicle. Okay, so you may have to do an orchidectomy. And at the time of, if you're doing an exploration and orchidoplexy, then you'd probably do it on both testicles, because whilst you're there, if you, for example, if a patient's got right testicular torsion, then you would do a bilateral orchidoplexy, because they're at high risk of it happening on the left-hand side. And the literature is slightly different, but you're most likely to salvage the testes if you do this procedure within 4 to 6 hours of the pain starting. So this is really quite time critical. Okay, so it's always worth thinking about this. Fine, so we've talked about acute limb ischemia, and we have talked about testicular torsion, and we've had a little sidetrack thinking about scrotal pain and edema, etc. So let's move on to our third case. Just having a good time. Okay, we're doing well for time, actually. Right. Okay. Right. Case number 3. This one's a little bit different. So renal colic. There we are. I've given you the diagnosis already, so we can all stop thinking for the next couple of minutes. So this is a case of renal colic. So I've got a letter. So this is a letter. So maybe I know you all work in different roles. So maybe if you're in a hospital setting, you're working on in a surgical assessment unit, doing a placement or or you're working there. If you're working in a pre-hospital setting, then maybe you're doing a transfer for this gentleman for whatever reason, or maybe you're the practitioner referring. So it doesn't matter what setting you're in. Just imagine that we've got this letter for this 74-year-old man who's been referred in by someone in the community. Maybe it's a GP, a paramedic practitioner, an AMP, who knows, with a one-day history of kind of loin pain. And he's had previous renal calculi in 2010, and he was under urology then. And we've done a urine dip in the community, and he's got 1+ of hematuria. And on examination, he's got some tenderness kind of around his left loin area. He's afebrile. His heart rate's 90. His blood pressure's kind of not very exciting. And we're wondering whether he's got a further episode of renal colic. So this all sounds relatively straightforward so far. This kind of 74-year-old man, bless him, who's sounds like he's forming some stones. So we probably know a bit about renal colic. I'm sure lots of you have all seen patients with renal calculi. It's very painful. Some of you have probably had this. It's very common. Lots of it's managed in the community, but some of it does end up in hospital, especially for analgesia or when your stones become impacted. And then we describe ureteric colic as being this kind of loin to groin type pain. So it starts in the loin, spreads down to the groin. And this is due to if your stone gets stuck or it's working its way down your ureter and you've got increased peristalsis, then those waves of muscular contraction cause the waves of pain to come on. And it can really be incredibly unbearable, and patients can be in significant distress. And lots of patients have microscopic hematuria, but not all, but most of them have microscopic hematuria. And then here's a nice picture. I just Googled this. I just Googled renal stones quickly, but if you just put it into Google Images, it's pretty horrific what some people have weed out of them. Yes, there's some pretty good examples of large renal stones if you want to go look at this. And then the management of renal stones, it depends on the size, it depends whether they're causing any obstruction, and it depends whether there's any complications, such as if the urinary system has become infected, then that's more urgent. So we're armed with all of this knowledge about renal calculi, and we've Googled them, and we're probably all looking at images now. I'm sure you're all doing that. Anyway, we go and see this man, and he looks a bit more sick than what we thought. He doesn't really look in pain. He just looks horribly unwell rather than rolling around on the bed in pain. Those of you that have seen renal colic, I'm sure patients are rolling around on the trolley or on the bed. They're really in a lot of distress. This man doesn't look like this. This man just looks terrible. So he's a little bit more hypotensive and a bit more tachycardic. He's put his respiratory rate up quite a bit. He's a bit cool peripherally. He's got a prolonged capillary refill time, and his abdomen's soft, but he's a bit tender. He's just generally very tender, kind of umbilical and suprapubic region. So has anyone got any thoughts on what could be going on here? What could our poor man what could have happened to him? Maybe I've led you down the wrong path with my letter. Hopefully I haven't. Kind of a not to miss surgical emergency in a man. Yeah, okay, yeah, someone's got it. Good. So he's bleeding from somewhere is what it sounds like. And what can mimic renal colic? Or let me flip it around another way. What diagnosis should you always consider in a 74-year-old man presenting with back pain who is now hypotensive and tachycardic? Well, of course, the diagnosis we always need to consider is, does this man have a leaky abdominal aortic aneurysm? Okay, that's what we always want to consider. So he's 74, he's got back pain, he's now hypotensive, he's tachycardic, and he's got a leaking AAA or abdominal aortic aneurysm. And this is just a CT image I've pulled off Radiopedia. I've put a large green arrow just to show you this is the aorta, and he's got what looks like a contained rupture of his aorta. And at the back here, you can see the vertebra, and at the front, you can see some bowel. Okay, so if you want to Google more about this, you can Google CT scans of AAA, but this is a nasty leaking abdominal aortic aneurysm. So lots of us know about AAAs. This is kind of what they look like. So we've got an intraoperative image here of a abdominal aortic aneurysm, and we've got a gross pathology specimen. So most of them occur infrarenally, so below the renal arteries. So you can see on the image the right renal artery. And you can see the kidneys, and then you can see this dilatation or this dilation of the aorta. So that's an aneurysm. So an aneurysm is just any abnormal dilation of an artery, normally due to weakened vessel walls. And this is normally due to atherosclerosis. So your risk factors for developing an abdominal aortic aneurysm are all of your risk factors for atherosclerotic disease, your heart attacks, your strokes, etc. So this is different to a dissection. This is different to a dissection. And I think we were talking about dissection, weren't we, in one of my other webinars, in the medical emergencies one, I think we talked about dissection. So this is just slightly different. So just so we've got the terminology correct. So an aneurysm is where, like I said, you get weakened vessel walls, and so the artery dilates outwards, so it widens, okay? And that's normally due to atherosclerosis. A dissection is where you get separation of the arterial wall layers. So that's where you get a tear in the inner layer of the artery, the tunica intima, and then blood enters the intima media space and dissects down, creating a false lumen and forming a hematoma. So they're two different kind of things going on here. And sometimes people use the terms interchangeably, talk about dissection and aneurysm. So they're slightly different. And the main risk factor for a dissection is hypertension, because anything that increases the pressure inside an artery, you're more likely to tear the intima. Hopefully that makes sense. So most aortic aneurysms occur abdominally. Okay, it's more common to get an abdominal aortic aneurysm, but you can get a thoracic aortic aneurysm. And then most dissections, generally, I believe most dissections are thoracic dissections, because that's where your blood pressure is highest, in your ascending aorta, in your thorax, when it comes out of the left ventricle. So dissection and aneurysm is different. Hope that makes sense, just so we can clear that up. So we all have heard of abdominal aortic aneurysms, probably. So, I mean, the technical definition, more than 3 centimeters or more than 1.5 times the expected diameter. Now, the problem is that They're usually asymptomatic unless they pop. Now, you can get maybe some symptoms. Maybe you might have a bit of back pain, maybe a bit of tummy pain, maybe some lumbar pain, but usually these are asymptomatic until they rupture. And when they rupture, you get sudden onset abdominal, back, flank pain. Patients might have a pulsatile abdominal mass, might present with hypotension, shock, collapse, syncope, or just they might present dead in cardiac arrest because of massive blood loss. So because these are usually asymptomatic, this is why we now obviously have the NHS screening programs, because we want to be able to pick up these aneurysms before they rupture so that the friendly vascular surgeons can do something about them. So that's why if you're a man and I can't remember the age, I think it's 65 or 70, I can't remember off the top of my head, you're invited for an ultrasound scan of your aorta to see if you've got an abdominal aortic aneurysm. And then you'd think that it'd be really easy to diagnose, wouldn't you, that this ruptured abdominal aortic aneurysm, but it's actually quite hard. So misdiagnosis of a ruptured AAA, it's a condition that's well known to mimic a few other things. And one of the things that it can mimic is renal colic. And that's what's happened in our man. So he does have a history of renal stones, but he's presented with back pain, and we've misdiagnosed him with renal colic when actually he had a ruptured AAA. And I've found this really interesting review. It's quite old, from the early 1990s, but they looked at 152 patients who'd had ruptured AAA, and they found that 46 were initially misdiagnosed. And the main misdiagnoses were renal colic, diverticulitis, and a GI hemorrhage. And the most common initial findings in misdiagnosed patients were abdominal pain, shock, and back pain. Okay, so just think, patient presenting with abdominal pain, back pain, and hypotension, think AAA, especially if they're over the age of 50. Or if patients have got a known AAA and they're presenting with abdominal and back pain or hypotension and collapse, think about the diagnosis. Okay. So treatment-wise, sadly, it's a bit, well, if you're thinking about AAAs that haven't ruptured, we tend to pick them up, obviously, under ultrasound, and you undergo surveillance. So it depends on how big your aneurysm is. And the cutoff for intervention is about 5.5 centimeters. So once your aneurysm gets to that, then you need to have a friendly vascular surgeon do something. Medical management's good. You need to stop smoking, control your diabetes, lose weight, etc. This slows the progression of the aneurysm. The bigger your aneurysm, the more likely it is to rupture, the more likely you are to die, essentially. And actually, quite a morbid fact is if your aneurysm is greater than 6.5 centimeters, you have to give up your driving license. You're not allowed to drive, because the risk of it rupturing, maybe whilst you're on the motorway doing 70 miles an hour, and then you suddenly collapsing and dying at the wheel and then causing lots of other injuries, is so high. And the mortality for large aneurysms is relatively high. For repair-wise, you can do an open surgical repair, or you can do an endovascular repair, and there's lots of debate in the literature about which of these is better. In an emergency setting, in an acute rupture, obviously patients have to be resuscitated, and then they tend to go for emergency open repair, but it's got very high mortality. Sadly, lots of these patients will die before ever arriving at hospital. The patients that do make it to hospital need to get to the right hospital. So remember, not all hospitals provide a 24-hour vascular surgery service. So if you turn up at your local district general hospital with your ruptured AAA and there's no vascular surgeon there, no one's going to be able to fix your leaking aneurysm. So you need to get to the right hospital. And generally, the patients that survive have what we call a contained rupture. So it's walled off, it's formed a hematoma, the bleeding has slowed down and stopped, and that buys them time in order for the vascular team to fix their aneurysm. But sadly, this has got a really high mortality, which is why we have the screening program, in order to try and, fix patients before they rupture. Right, so this is all a bit morbid. I'm sorry about this. So we've talked about abdominal aortic aneurysm, and we've talked about testicular torsion. So let's move on and have a look at our fourth case. I'm not doing too badly for time. Okay, so this is faint. This is our presenting complaint. So this is someone that's fainted. So let's have a look at this in a bit more detail. So this is a 32-year-old female. So she's basically had a fainting episode today whilst getting up out of the chair at home. And her husband's really worried about her. He kind of describes her standing up, getting out of the chair, and kind of just falling over and fainting. And she did the classic thing, was very pale, had some pre-syncopal symptoms, maybe felt really rubbish afterwards. The backstory to this is she's had this terrible abdominal pain for about 2 or 3 days. She just feels rubbish and nauseated. And she thought it was gastroenteritis. So husband's had a bit of a dodgy tummy, had a bit of D&V, maybe had too many lockdown takeaways, who knows. The pain's sharp. It's kind of left lower quadrant, but it's now kind of radiating across all of the lower abdomen. It's constant, severe. She's tried analgesia and hot water bottles, no relief. She says there's absolutely no chance of a pregnancy because she's got a coil in, an IUCD, and she kind of rolls her eyes when you start asking about all of that. And she's got a bit of mild asthma, salbutamol, and she's independent. She's 32. So this is our presenting complaint. Yeah, there's lots of differentials coming up already, which is good. So when you see her, she looks a bit rubbish once again. She's feeling unwell, she's clammy, she's a bit pale. She's a bit hypotensive and she's tachycardic, and she's a bit shut down peripherally. She's got prolonged capillary refill time, and she's very tender over her lower abdomen with rebound tenderness and guarding. Good. So what do we think about our working diagnosis? So there's quite a range of diagnoses here popping up, which is good. But lots of you are picking up on what the most likely diagnosis here is. I didn't lead you too astray, hopefully, with with her contraceptive history. So the most likely diagnosis here, this is a 32-year-old who's presenting with kind of severe abdominal pain, who's now hypotensive, shocked, and tachycardic. Kind of what we're worried about here is probably we're worried about a ruptured ectopic pregnancy. And this isn't the definite diagnosis yet, because we obviously need to do a pregnancy test and an ultrasound scan. But what I'm worried about here is a ruptured ectopic. So let's think about this in a bit more detail, and let's think about how the coil is relevant here. So we obviously probably all know what an ectopic pregnancy is. It's a pregnancy that implants outside the uterine cavity. It's relatively common, so maybe around 11,000 a year in the UK, according to NICE. And there's a couple of risk factors that increase your risk of having an ectopic pregnancy. So if you've had one before, you're at increased risk. Anything that damages your fallopian tubes. So for example, if you developed pelvic inflammatory disease from a sexually transmitted infection, or you've had surgical procedures, anything that damages those tubes increases your risk. IVF does, smoking, kind of a maternal age of the age of 35. And then, yeah, contraception failure. So in Our Lady, she's got a copper coil in an intrauterine contraceptive device. So that reduces her, obviously, her risk of pregnancy, but they're not foolproof. So they're around, you know, it's around just under 1% failure rate of the coil devices. That's both the copper coil and the Mirena, which is the intrauterine system. So there is a risk of contraceptive failure. And in those patients who have contraceptive failure, so if you manage to get pregnant with the coil in situ, then the risk of ectopic is around 1 in 20. Okay, so it's pretty high if you actually manage to get pregnant with a coil in situ. So that's probably what's happened to Our Lady. Okay, and then they've just got an image here about, just if you remember your anatomy, most ectopic pregnancies end up in the fallopian tubes, although they can end up in various other places. So for example, if you've had a previous cesarean, then the scar tissue, sometimes the pregnancy can end up there in the scar tissue, but most of them end up in the fallopian tubes. Fine. So the bottom line is, is no method of contraception is 100% reliable. I guess apart from complete abstinence, and then I'm sure people would still find a way of getting pregnant. But no method of contraception is 100% reliable. So even in this patient who's saying that, you know, she's got an effective method of contraception, it's always worth, she's a woman of childbearing age, presenting with severe lower abdominal pain in the context of hypertension, tachycardia, shock. We're worried about ectopic pregnancy. So don't exclude the diagnosis based upon someone's contraceptive history. So NICE suggests you should suspect ectopic pregnancy, kind of any woman that presents with abdominal or pelvic pain, amenorrhea or a missed period, or PV bleeding or discharge. So all of these, and there's kind of an old adage, isn't there, in emergency medicine or kind of anyone doing urgent care, kind of everyone gets a pregnancy test, don't they? We assume everyone's pregnant until proven otherwise. So I'd have a very low threshold for pregnancy testing. And certainly in A&E, it would be a cardinal sin to see a woman with abdominal pain and not to perform a pregnancy test. The diagnosis of ectopic pregnancy is a consistent area of concern, and the Healthcare Safety Investigation Branch, which I think was Jeremy Hunt's idea, who to kind of investigate patient safety incidents, are looking at the diagnosis of ectopic pregnancy. So you can go on their website and you can have a look at this patient safety investigation. And they showed it that in just over a year's period, there were around 30 missed ectopic pregnancies that led to serious harm. So this is something that is still being missed. So it's worth knowing about this. And just obviously the complications of an ectopic pregnancy, we're nearly done, don't worry. Just what we're worried about is if the pregnancy implants in the fallopian tubes, as it grows, then eventually there's the chance of it rupturing the tubes, and then that leads to massive hemorrhage. So that's what we're worried about. So we're worried about hemorrhage. So I've just got an intraoperative picture to show you not on this slide, on the next slide. So what we're worried about is rupture of an ectopic, which is a time-critical surgical emergency because of massive hemorrhage. So not all ectopics will rupture by the time they're picked up. So thinking about management, in your stable patients who the ectopic hasn't ruptured, they may be suitable for medical management, or even in some cases conservative management. But this depends on lots of things. It depends on the ultrasound scan findings. It depends on the beta HCG tests. But in some patients who it hasn't ruptured, it may well be suitable for medical or conservative management. If we're going to do surgical management, then it's normally a laparoscopic approach, a salpingectomy, which is where you remove the ectopic and the tube, or if there's evidence of tubular damage and we want to preserve fertility, then a salpingotomy, which is where you try and preserve the tube and just remove the ectopic pregnancy. But this all depends on the location of the ectopic, but that's generally going to be our surgical approach. And then this is my picture. So just to show you, imagine this is a laparoscopic camera picture. Imagine the camera has gone in the belly button and is kind of looking down into the pelvis. That's the best way to think about this. So in blue, we've got the uterus, the womb, and in red, we've got an ectopic pregnancy developing in the fallopian tube. Okay, and you can see that this is actually ruptured because there is a large amount of blood sitting down there in the bottom. We've got the pouch of Douglas, we've got the pelvic cavity, and you can see there's lots of blood here. So these women, when this happens, if they have a massive hemorrhage, then they basically have a belly full of blood. So they suffer massive hemorrhage, and lots of them may require resuscitation, blood transfusions, etc. Okay, so that's just to give you, I'll put this image in just to give you an idea of what we're worried about here is hemorrhage. Okay, we're worried about massive hemorrhage. Fine. Okay, so is this the last gory picture? I'm not sure. Oh no, there might be another one. I'm sorry. Right, so we have talked about a couple of things. We've done 4 cases. We've talked about acute limb ischemia, and we've talked about testicular torsion. We've talked about renal colic that was actually turned out to be an abdominal aortic aneurysm, and we've talked a little bit about ectopic pregnancy. So we've done our 4 cases. Just to finish off with, there's just one thing I want to mention, because this is obviously 5 surgical emergencies not to miss. Just beware of cellulitis, okay? This is just based upon a patient I saw when I think I was still a student. But just beware of cellulitis, which is a very common complaint. And any of you working in practitioner type roles or primary care, we see lots of patients with cellulitis. It's relatively common, and usually it's pretty benign. But obviously, always beware about the necrotizing fasciitis, which is our final surgical emergency that we're going to finish off with. And I'm using an infographic from EM3, which is run by a group of emergency medicine trainees in the East Midlands. You can go on their website, em3.org.uk. They've got these great kind of simple infographics about various conditions. So go check them out. They're really good. So necrotizing fasciitis is just a diagnosis you don't want to miss, and it's a surgical emergency because the treatment of this is surgical debridement. Antibiotics, yes, but really you need surgical debridement. So neck fash is what kind of you read in the Daily Mail and other newspapers. They call it the flesh-eating bacteria or the flesh-eating disease, which is a bit dramatic, isn't it? But kind of necrotizing fasciitis is where you get infection. It kind of tends to start off in the superficial fascia, and the infection get organisms that grow. They release lots of enzymes, proteins, and that causes necrosis of these fascial layers. And therefore you get spread of infection into the skin and then down into the deeper structures. Okay, so your infection spreads through your fascial layers, and then you get thrombosis of your arteries and your veins, and this leads to ischemia and necrosis, and it's just very horrible. It's completely devastating. It's got high mortality, incredibly high morbidity, and it can occur. There are risk factors. So if you're immunocompromised, if you've got diabetes, I don't know, if you're an intravenous drug user, then yes, that puts you at an increased risk. But this can occur in completely healthy young adults, etc. They tend to get streptococcus, I think group A strep, they tend to get. So don't think that this is just a diagnosis that occurs in your comorbid, multimorbid patients. This can occur in young, healthy people as well. And really, any soft tissue infection that's rapidly deteriorating, and one of the classical features is disproportionate pain in the early stages, should make you think about necrotizing fasciitis. And there's just a couple of pictures here that show you the stages. So you start off with the standard erythema, swelling, but very tenderness beyond the area of affected skin. And then you get this blistering, these large bulla formation. You can get crepitus, lots of serous fluid being discharged. And then you get necrosis, tissue breakdown that leads to gangrene. And this progresses very rapidly. And the mortality increases significantly with delayed diagnosis. So this is just always a surgical emergency to keep in your back of your mind. And you may have heard of something called Fournier's gangrene, which is when this affects the perineal, genital, perianal regions, and that's got an even higher mortality, and that can be very devastating as well. So this is something that is missed. If you have a look in the medical literature, it talks about these cases are missed. So it's always worth keeping this in the back of your mind. It's incredibly rare. So don't go around admitting every patient with cellulitis to the surgeons worrying about neck fash. But it's always something to keep in the back of your mind. And this is another reason why safety netting is so important. So we talked about safety. When did we talk about safety netting? I can't remember. In one of the other webinars, we were talking about safety netting, but this is just another reason why, even your patient with simple cellulitis, 20-year-old, simple cellulitis, you give them some flucloxacillin, always safety net, okay? It's really important because you never know if they do get worse, then they need to know what to do. So if you want to read a bit more about necrotizing fasciitis, like I say, I've only seen a handful of 1 or 2 cases, then there's a link down the bottom here, and I'll post a link in the Facebook group too. But just keep this in the back of your mind for all of your run-of-the-mill cellulitis patients. Fine, so I think we're about done. So we've been on a whistle-stop tour through 5 surgical emergencies. As always, if you've got any questions, sometimes it's just easier to email me. If you've got anything, I don't mind. If you want to email me, that's fine. And then this is the topic list. So I think I say this in every session, but this is, we've only been going for about an hour, 45 minutes or so. I don't have time to go into all of the intricacies of each of these conditions, and we haven't spent a lot of time talking about examination. So go away, have a look at these topic lists, do a bit of additional reading and research to cover the areas that we haven't had time to talk about. And to support you in doing that, I will post a couple of links that I think are really good in the CPD-Me Facebook group. Fine, so I think we're done.
Super. So I'm just going to run through the questions on the case-based side. So for the first case, we have Lyndon that says, I went to a patient some years ago, presented with pain, paler and cold limbs, but en route to the vehicle, it all reversed and then represented just as we arrived at hospital. Why do you think that would happen? Why would you think they would almost reverse?
That's really interesting, isn't it? I'm not sure. Maybe they were having embolic events and they were throwing off clots and kind of, disrupting the circulation to their leg and then clearing it by themselves and then having another clot. That sounds really interesting, though. I mean, that could be one theory. Either that, or it could be the movement, I guess, from transporting them and transferring them, dislodge them clots to restore circulation. Or it could be the evolving atherosclerotic plaque rupture that's letting a bit of blood through and then occluding again. Those are my thoughts off the top of my head. I don't really have a magic answer, I'm afraid.
No problem. Thanks for that, Chris. And thank you, Lyndon, for that question there. And just a comment, a sort of second comment on case one, really, not really a question. But Louise says she's not heard of the 6 Ps and has just had to remember them. So it's a nice and easy way to remember them, how you've explained it there, Chris. So thank you.
No worries.
Super. So moving on to the second case, we've got Deborah that's just asking why would they twist? Why would they twist around?
Yeah, that's a good question. So you can have deformities, or you can if your testes can be in a slightly different position to begin with. It's kind of like a congenital problem. It's called a bell clapper deformity, and that puts you at an increased risk of testicular torsion because your testes isn't anchored properly in your scrotum. That's the best way I can think about it. So it might be something that you're born with. So you've got this kind of predisposition to have a slightly mobile testes, and then suddenly it twists round. So that's one possibility. The other possibility is it can be related to trauma. So there's some sort of traumatic event, which can be relatively mild, like an awkward tackle or a blow to the scrotum that causes the twisting to occur. But I mean, at the end of the day, without wanting to be too crude, kind of testicles dangle, don't they? And they dangle by something, which is the spermatic cord and the associated structures. Therefore, anything that kind of dangles on a thread or a string is at risk of twisting round. So that sounds really crude, but that's kind of I mean, that's why it occurs. And I guess you can argue it's a fault in our design, isn't it? Or our evolution, or whatever you believe. But yeah, we're at risk of this. And in the perfect world, we wouldn't be at risk of this. But it's just the way that the testicles lie, and because they're dangling, there's that risk of them twisting round.
No, that makes sense. Thank you for that, Chris. And I think sometimes needs that crude explanation to help. So thank you for that. Just a sort of final point on the second case, Gemma's just saying, I'm sure pain relief is subject to the individual, but would Entonox work effectively?
Yeah, give them everything. I mean, I've got a lot of sympathy. It's really painful. It's horrible. I've seen patients with it who are just a complete mess, in the surgical assessment units. They're in significant pain. So I think give them whatever you've got. And Entonox seems pretty good to me. It's rapid onset. It's going to at least get rid of some of that is going to take the edge off that pain. So yeah, I would be kind, give it to them.
I agree. So the next one, we're going to move on to the third case. And Stephen said, I read that thoracic aneurysm dissection can present like a stroke when it dissects near a carotid arteries. Is that the case?
Yeah, I can't remember if we talked about this in the last session, but yeah, that's completely correct, because you need to know a little bit about the anatomy of the aorta. So you can always Google that and have a look at that diagram. But if you think about your ascending aorta, comes out of your heart, loops over, and then heads down your thorax and into your abdomen, and it gives off lots of branches, doesn't it? So it gives off your branches to your brain, your carotid arteries. It gives off branches to your arms, your kind of subclavian, your brachiocephalic artery. So it's giving off all of these branches. So the dissection, this tear in the tunica intima, between the intima and the media, as the dissection progresses along the aorta, think of it starting at maybe the base of the aorta, and it's kind of progressing round. If it interrupts those branches of the aorta, then it will interrupt the blood supply to what that branch is supplying. So for example, if the dissection interrupts the carotid artery, then you can get neurological problems. So in some cases, it can even mimic a stroke. But patients might present with, paralysis or functional deficits. But the reason for them is because we've disrupted their carotid artery, or it goes round and it disrupts one of the arteries supplying their arm, and that's why you get a blood pressure differential between their left and right arm, because one of the arteries supplying the arm is disrupted, whereas the other one isn't. And then this can go on. So if the dissection does go down, further down, maybe into the abdomen, then it can affect the renal arteries, and patients can present with an acute kidney injury and renal failure. So there's a great thing. I can't remember the citation off the top of my head, but they talk about chest pain +1. So chest pain plus something else should make you think of dissection. So for example, chest pain plus signs and symptoms of a stroke should make you think, could this be a dissection? Chest pain plus, evidence of arm ischemia or arm pain should make you think dissection. But I can't remember the citation, so I'll have a think about it and I'll post it in the Facebook group.
No, that's brilliant. Thank you for that, Chris. And thank you for that question there. We're just going to move on to the last two cases and just cover a couple of final questions on each, just to close off this evening. So on the fourth case, and we've got a question from Carl, who says, how effective are pregnancy tests in ectopic pregnancies?
Okay, I'm not an expert on this. I'm going to say that right at the beginning. It depends on the beta HCG, because obviously a pregnancy test is just kind of detecting for things in the urine. So it does depend on the beta HCG, but I'm not an expert in this area. My wife is actually a sexual health doctor and works in obs and gynae, but I can't go ask her. So yeah, I'm not sure. I would have thought they would be effective, but generally in clinical practice, if we're managing someone with suspected ectopic, we do a serum beta HCG. That's what we would do.
Super, thank you for that, Chris. And just moving on to our final case. And Ryan's asking, what are your thoughts on the link between ibuprofen use in chickenpox for the risk of neck FAS?
So I'm not that familiar with the evidence on this. So I'm not sure I can really comment on that, to be honest. I'm sorry. It's not an area I'm completely familiar with, I'm afraid. This feels like I feel like I've given really two bad answers to the last two questions, but I don't really have a strong enough opinion, and I'm not that familiar with the evidence. But maybe someone can look it up for us and post it in the group. It's something I remember in the back of my mind from medical school, but yeah, I'm not au fait with all the latest evidence.
No, that's brilliant. So if anybody does have any sort of thoughts on that, then feel free to comment in our chat side, and we'll pick that up and we can post it on our CPD page as well. I'll give you one final question there, Chris, and hopefully I'll be kind to you with this one. Is there any association with cellulitis and pitting edema?
Yeah, so if you've got kind of cellulitis, then you can develop edema, can't you? But also it's kind of a two-way relationship, isn't it? In that if you've got edema from another cause, for example, if you've got lymphedema, or you've got, I don't know, a kidney problem, you've got nephrotic syndrome and you're very edematous, then that buildup of fluid makes you more at risk of cellulitis as well. So it kind of works both ways. It can be really difficult, actually. I'm sure lots of you will have experienced this in older patients who've got edematous legs. They're a little bit red, you know, and you're kind of looking at them thinking, is this cellulitis? Is this a DVT, or is this just normal for them? And maybe they've got another dermatological condition. So it can be really difficult. But yeah, the two are definitely related. So if you've got kind of chronic edema, that's going to put you at risk of cellulitis. Then you can develop edema if you've got a bacterial infection, and obviously you can develop quite significant edema and tenderness with neck fash as well.
Super. Thank you very much for answering that final question there, Chris. And thank you to everybody for all your participation and for all your questions there too. Thank you very much, Chris, for another engaging session and another case-based learning session. So what we're going to do is I'm just going to wrap things up for this evening, and just go through what other things are coming up, what other webinars are coming up and so on, so that you can get involved in more CPD. So what you should see is our Facebook page on your screen there. So this is what Chris has mentioned throughout his talk, really, in posting useful resources on this page. So if you go to facebook.com/groups/CPD Made Simple, you'll be able to join our group and access all the free resources that we post on there. This isn't just CPD resources, this is resources from everywhere that we can find that are freely available and act as great information to you guys. So feel free to share this with your colleagues, feel free to join, and also share some useful content yourselves on there so that other people can benefit from that shared CPD. Something new and exciting this week, so we are coming to you on Wednesday at 4 p.m. live, and that's going to happen every week for you to ask the team just a quick 20 minutes, just ask the team any questions that you may have in how to use CPD-Me. Maybe you need some help and support or guidance in building your portfolio. You can join myself and Alistair at 4 o'clock every week, and we'll be able to answer any of your questions. Now, if you do have a question that you want to send in advance, perhaps you can't attend live, but you want to post a question and have access to that recording afterwards, then please feel free to email us at question@cpdme.com. You can also, if you should have received an email with a form where you can submit questions to as well. So there's always multiple ways to get your question answered, and we will make sure that that's done as part of one of our sessions for you.